Hi, everyone.
Các điện ngoài ngành cái hình này là order là họ.
Không ở đâu nữa. Không bằng送来了，一路送来的。
Oh, the Brexit Road.
I don't say it.
Isn't it fun listening to the sounds of the city? Guys, I'm so excited about this episode. We have so much.
Quái phim hồi xưa
everyone.
Hi, Wendy.
We'll give it a few more minutes, not too long. We got so much to cover. Give it another minute.
Please. Yeah. He's stupid. Anyway.
Come on, everyone. Come on. Get off those streets of New York and get into the meeting. Okay, let's get it down. We'll get started. Right. We're going to wind it down. Good evening, everyone. Hi, everybody. Look where we are. So, good evening and welcome to Generational Dermatology, GDermFresh. I'm Dr. Wendy Roberts, founder of Generational Dermatology, and Generational Dermatology addresses the needs of the evolving aging patient. In practice, it's not waiting to treat something tomorrow that you can anticipate and prevent today. Our experts will weigh in, but maybe an example is the best way to combat facial acne is identify risk factors and early signs while our patient's evolving, but more about that later. I practice in Palm Springs, and this is where our annual meeting is live every President's Day weekend. But of course not this one, thanks to that 5-letter word, right? COVID. So in response to COVID, we're doing these monthly live Zoom meetings. And these episodes really have been a silver lining. And that is that we're building such a terrific community, and this virtual community has connected even beyond the monthly meetings. So please go to our website, generationaldermatology.com, where you can see highlights of past meetings, connect with presenters and industry sponsors, and even order our beautiful GDermFresh box. This box is loaded, literally, as you can see. We've got pens, pads, products, everything. I like to equate it to delivery of an exhibit hall in a box coming straight to your door. Think of it like that. And just like our exhibit hall treasure, if you're not interested in these products, somebody in your home is. You will watch them disappear. So what's in the GDermFresh box? Well, order and find out. They're really great. I want to thank all the sponsors who've contributed to the box. And most importantly, come on, write the date down, because we're going to make up for last year. And those of you who have been to GDerm know not only is it so much learning, it's so much fun. And our live meeting is February 18th to the 20th, 2022 at the beautiful Omni Resort here in Rancho Mirage, California. And again, we want to thank all of our sponsors who have contributed to these meetings since we started them in January. Tonight, we have 3 excellent sponsors, Airlays, Aberdeen TheraWorks, and GoMD by Aesthetica MD. So, housekeeping items, we'll be taking questions all night. We're 5 to 7, all through the Zoom. We're going to be taking questions. So I encourage you, please write any questions you want in the chat box and promise you they will be answered. So it's June, right? Everyone knows it's June. And we all know that June is Acne Awareness Month. So, I just thought it was so appropriate as we begin to open up the country, and particularly New York, that one of my favorite cities. I couldn't be any happier to bring two of New York's finest to GDermFresh. Both are beloved GDerm faculty, amazing world-class speakers, and right here on our Zoom tonight. And I'm so excited. So is everybody ready? Without further delay, live from New York, it's GDermFresh episode 6. And our first speaker is Dr. Andrew Alexis. Dr. Andrew Alexis, again, is a GDerm veteran. And thank you, Andrew, for always doing this meeting. He's the Vice Chair for Diversity and Inclusion for the Department of Dermatology at Center for Diverse Skin at Weill Cornell Medical Center in New York City, and the former chair of the Department of Dermatology at Mount Sinai. Everyone knows Dr. Alexis and his work really that he's done to advance patient care and research in skin of color is remarkable. He's also co-founder of one of my favorite meetings, Skin of Color Update. And Andrew, please let us know when all that is. If you haven't been to that meeting, you've got to go. Especially if you're on the East Coast, no excuse, got to go. He's published more than 90 articles and peer-reviewed. He's co-edited 2 textbooks, authored textbooks, and has sat on numerous committees. I think most importantly, he's one of the nicest guys in dermatology and smart as well. So thank you so much, Dr. Andrew Alexis. You're going to talk to us tonight about barrier. I'll let you take it from here. Welcome.
Well, Wendy, thank you so much for your very kind and warm introduction. And thank you for letting me be part of your 6th episode of GDermFresh. As you know, I'm a huge fan. I've enjoyed personally going to Palm Springs for your live meeting every year, with the exception, of course, this year for obvious reasons. But really a highlight of my year coming down to Palm Springs for Generational Derm. Great meeting if you haven't been to it already. Thank you also, Wendy, for the opportunity to share tonight's program with someone very special to me, and that's Dr. Diane Berson. Everybody knows Dr. Berson, but you may not know that we do go way back. Dr. Berson was one of my attendings way back in the day when I was a resident at Weill Cornell. And not only did she teach me all sorts of amazing clinical and therapeutic pearls that I still use today, but she's just an immensely kind and wonderful person that I'm just happy to know. And it's great to be able to, and it's an honor really to share tonight's program with her. So today I'm going to talk about skin barrier, and in the theme of generational derm, I'm going to discuss the role of how does skin barrier evolve over time as we age. And then given that I'm partnered with Dr. Berson, who's going to talk about acne, I thought I'd touch on any overlaps between what we know about barrier and acne. So with that, just before I get started, these are my disclosures. Not sure if any of them are particularly relevant tonight, but just wanted to show those. And so I'm going to begin with a basic quick review introduction about barrier. We all know it, but repetition never hurts. And then I'll discuss some of the specifics of how the barrier changes with age, and then launch into some of the barrier changes that might be less well known when thinking about acne. So taking a step back, what do we mean by epidermal barrier? Well, of course, I don't think anyone in this audience really needs to be reminded of what the epidermal barrier is, but it's often nice to think about its importance with respect to protection against water loss, preventing entry of bacteria and viruses and irritants and allergens. So this epidermal barrier is so critically important. And the top layer, the outermost layer of our epidermal barrier, of course, is the stratum corneum, which is a multicellular, vertically stacked layer of cells, which is embedded within a hydrophobic extracellular matrix. And this is often described as a bricks and mortar sort of structure, where the bricks are the corneocytes And the mortar is the material between the corneocytes, which is made up of free fatty acids, cholesterol, and a number of different ceramides. In fact, ceramides make up about 50% of that intercellular mortar, the extracellular matrix. Within the corneocytes, there is a substance called natural moisturizing factor, and this is generated by breakdown products from filaggrin. So quick review there. Now, as we can all appreciate from taking care of patients, alterations in the lipid content and other factors of the barrier have important relevance in a number of conditions and treatments that we see every day. And specifically, alterations in lipid content can contribute to defects in the barrier structure that correlate with increased transepidermal water loss, or TOOL, and enhanced permeability across the barrier. Some of the common perturbations of the barrier that we encounter every day are a number of the dermatologic disorders that we see frequently, such as atopic dermatitis, others that we see less frequently, like ichthyosis. Topical therapies, certainly many of our therapies can disrupt the barrier. Skin care, especially that done by our patients before being counseled by us, can often be irritating and disrupt the barrier. Some of the procedures we do are sort of controlled injuries to the skin and can induce some temporary disruption in the barrier, including peels and laser resurfacing. And then there's the things we cannot really control, and that's age and how the barrier evolves over the decades, and we'll talk about that. So and this is an example of a woman who's experienced severe irritation after using tretinoin 0.05% gel, and probably over-applied and wasn't really adherent to recommended skincare, and developed this dryness and peeling, and you can see erythema and hyperpigmentation. And this is just one example of the manifestations of barrier disruption induced by our treatments sometimes. What about the microbiome? Increasingly, we're appreciating the importance of the microbiome. In fact, the microbiome actually contributes to a healthy skin barrier, where a diverse microbiome is associated with a healthy barrier, and shifts in the microbiome can adversely affect barrier function. And just to illustrate, in this schematic on the left, we have healthy skin with a normal microbiota, a lot of diverse species, whereas on the right, we see an overproduction, overrepresentation of a pathogenic bacteria, in this case, staph. And so a lack of diversity or loss of diversity of the microbiome. So we describe this as dysbiosis. And this has downstream effects in terms of inflammation and disruption of the barrier. And we can see this in atopic dermatitis as a great example. So what about age? How does the barrier change over time? Well, as the skin matures, the epidermis thins, there's slower keratinocyte turnover, reduced stratum corneum lipid content, and a loss of that acid mantle, loss of acidification with advanced age. This has implications for wound healing. There is a tendency towards scaling as a result of increased corneocyte retention, and of course, xerosis being more common in mature skin. And this all can contribute to increased susceptibility to pathogens. Now, when it comes to specific components of the barrier over time, such as ceramide content or natural moisturizing factor, we see gradual declines as we get up there within the decades. Beyond the 30s over through to the 70s, we see a gradual decline. This graph shows declines over the decades in fatty acid content, ceramide content, and cholesterol content over time in the stratum corneum. pH, there is a from the time we are born, there's a rapid decrease in skin pH down to the normal acidic pH of 5.4. And it generally stays there for decades through childhood and early and adolescence and early adulthood. But as we get into the advanced higher decades, we start to see an increase in pH, especially after the age of 70. And this effect is especially marked in the lower limbs. And increased skin surface pH and protease activity lead to reduced stratum corneum cohesion with age. And another change is the levels of this enzyme called KLK5 or kallikrein-related peptidase 5, which regulates desquamation. Declines in this enzyme occur over the decades and contribute to some of the xerosis and reduced desquamation that we see in advanced age. What about the microbiome? How does that change with age? Well, you guessed it, even that seems to decline. The amount of microbiome diversity reduces from the 5th decade and beyond, as shown here. So this is really sounding like a very depressing lecture where everything just seems to decline with time. Don't worry, hang in there. Once Dr. Berson comes on, we're going to hear some great solutions to a lot of these issues. Now, what about acne? Is there any effect of acne on the skin barrier? I'm sure we can imagine effects of our treatments on the for acne on the barrier, but does acne itself affect the skin barrier? Well, I think this is an area that's not well understood or well known by most just yet, given the paucity of studies. But it's interesting that there is some evidence for disruptions in the barrier as a function of acne itself. In fact, this Japanese study looked at a number of different barrier functions and found that patients with moderate acne were noted to have increased sebum secretion. No big surprise there, as you would expect acne patient. But here's where the surprise is. Increased transepidermal water loss and lower stratum corneum hydration were seen in moderate acne compared to controls. For both mild and moderate acne patients, lower ceramide content was seen, and the change in the composition of stratum corneum lipids was observed in the acne patients compared to controls. And so this is something that I think that deserves further study. Another study looked at skin pH and found that there's a loss of that physiologic acidic pH and an gradual increase beyond that ideal, around 5 to 6 pH. In fact, in acne patients, only 22% had a physiological skin surface pH compared to 93% in the control group. And this is a pretty sizable study, 200 patients in each group. A much smaller study, this was a 1-year longitudinal study, looked at seasonal variations among other things. And they found that transepidermal water loss was higher in acne patients with an increase in the colder months. And this is taken right from the study, where you can see that they measured transepidermal water loss at these 2 facial sites. And you can see some seasonal variation with highest transepidermal water loss in the winter months. But the shaded bars here represent acne patients, whereas the clear bars represent non-acne patients. And you can see greater transepidermal water loss throughout the year versus non-acne patients. So higher in acne patients compared to non-acne. Now, when it comes to treatment, it comes as no surprise that many of the treatments we use for acne can disrupt the barrier, and this has been measured and reported as a function of increasing transepidermal water loss. In the case of benzoyl peroxide, in dose-dependent fashion, tretinoin and tazarotene. But as far as solutions to this problem, and Dr. Berson is going to get into some helpful tips as far as how to get around these issues. But one such piece of evidence that can help guide practice is a nice study from a few years ago by Dr. Tanghetti and colleagues, where a ceramide-based moisturizer was applied twice daily including 20 minutes prior to tazarotene cream. So the nighttime application of the moisturizer was done 20 minutes before the retinoid, which goes against what is traditionally done, where you put the moisturizer on after the retinoid. And what they found is that there was better tolerability, reduced retinoid-associated dryness and irritation, but without a loss of efficacy. So there was a comparable reduction in mean acne severity scores over the course of this study. So this is allows us to use an alternative for those with particularly sensitive skin if you want to moisturize first before putting on the retinoid without compromising on efficacy. So putting it all together, when thinking about our acne patients, we have to remember that inherently they might have barrier disruptions just from the acne itself. We compound that with some of the agents that we use that can disrupt the barrier. So we have to think carefully about the molecule we're using, the concentration, the vehicle, the dosing regimen, and especially concomitant skincare. And I know Dr. Berson is going to help elaborate on that and give us helpful pearls. So with that, I close with a picture of the Brooklyn Bridge taken by my wife a number of years ago. And I thought it was apropos as we have Brooklyn's own Dr. Diane Berson following me. So I'll stop sharing.
Thank you. Thank you, Andrew. That was great. Terrific. If we have any questions, don't forget to send in questions. So Andrew, I've got a question, just a quick one. When do you think we should start talking about barrier with our patients?
Well, great. Thanks for the question. I might be kind of biased, but I think it's never too early to talk about barrier, because the barrier is relevant to every single stage of life, and in many of the disease states that we treat, there is a role for protecting the barrier. So there's no time like now. Start. It's very relevant
Right. At the very beginning. So yeah, you know, the talks are meshed so well. We're going to do barrier, and Dr. Berson is going to speak about acne, and then I actually have a winning product showcase that is a barrier and acne product that we're going to be talking about. So it just hang on, guys. It's just everything just comes together, and it's just going to be a great evening. So I'd love to introduce my dear friend, Dr. Berson, who's an associate professor of dermatology at Weill Medical College of Cornell. She has been in private practice in dermatology. She teaches medical students, residents. She's a wonderful mentor. She focuses on medical, surgical, and cosmetic dermatology. And we all know her name because she has published so much in acne all over the world. She's one of the editors of Practical Dermatology, JDD. Dr. Berson is currently on the board of directors of the American Academy of Dermatology. She is a past president of the Women's Dermatologic Society and a media spokesperson. And I know that there is another past president of the Women's Dermatologic Society who came to visit tonight. I thought I saw you.
Hi, girls. Diane,
Hey.
Wendy, my partners in crime with WDS. And I just want to give everyone a little tease. I wanted to surprise Diane and be on the call. I am in my automobile with my virtual background of cosmetic boot camp because I have a baseball game for my 7-year-old grandson. But in honor of Wendy and her wonderful meeting, anyone on this meeting who would like to join us, Diane and Wendy and I are going to be at Cosmetic Boot Camp. DM me through Instagram, and you have a special little discount treat that I'm going to give you in honor of my favorite women in the world. So with that, I'm going to hand it over to Diane.
Oh, Mary, thank you. Thanks for coming on. That's
Bye,
great.
everybody. I've got to go to my game.
Drive
You an
carefully,
ass,
Mary.
man.
Okay.
Bye. Thank you.
Okay, we'll take Dr. Berson's talk now. Wow, that was nice.
Hi,
Take advantage of that. That's a great meeting.
How do I get, I had my,
We'll go ahead, yeah,
I had my presentation up before,
Hi, Dr. Berson. You are going to have to share again.
but I lost the presentation again. Okay.
okay.
Oh, there we go.
Yeah.
Do you guys see it?
Not yet, but we did see it.
Oh, I have it, but I lost
You
it.
have to reshare the screen.
So I can't ask by hands, but while Dr. Berson's getting her slide on, I just curious, how many people talk about barrier? You know, how many people even discuss it? And if we discuss it, you know, what are we saying? What are we saying to our, what are we saying, telling our patients? Anyone can, you can, oh, here we go. Okay, hold on to that question. I'm gonna come back to it.
All right, well, first, Wendy, thanks so much for inviting me tonight for your New York panel. And I am also similarly honored to be doing this with Andrew, Alexis, and so proud of the dermatologist he has become. He really was one of my favorite all-time residents, and we had just such a wonderful time working together and rounding together. And he has just become an incredible leader in our specialty, and I feel like a proud mom. And I'm so thrilled that he's back at Cornell with us, and I'm honored to be on this panel with him. And so thank you, Wendy, and thanks, Andrew, for letting me share this panel with you. And as Andrew, Dr. Alexis alluded to, I'm going to sort of talk about the skincare aspect of acne, since our focus tonight is on the barrier. But because the focus of this conference is generational acne, I just thought that I would basically review the fact that acne is something that we have from birth until the end of our life, and it is not something just we see in adolescence. So this is a photograph of a baby with what we refer to as neonatal acne. And neonatal acne actually can occur in the first few weeks of life. It's often just little comedones, usually not much inflammation. And it usually resolves in the first few months of life. And there's not a relationship between neonatal acne and adolescent or teenage acne. And usually this is just due to transfer of maternal androgens into the newborn and stimulating sebaceous glands. So this is something that's really transferred from the mom. And this is as opposed to acne that we might see a few months after birth, and we refer to that as infantile acne. And in this acne, you can actually see inflammatory lesions along with the comedones. Usually occurs about 6 months of age. And this could be due to a precocious secretion of androgens or gonadal androgens. And this can eventuate into scarring. And if this really continues until about a year of age, a workup actually should be done on these little babies. Now, what happens at adrenarche is the adrenal gland kicks in. And when the adrenal gland kicks in, we start seeing breast buds and axillary and pubic hairs. And we actually start seeing a little oiliness of the T-zone, the forehead, and the nose and the chin. And we start seeing the beginning of comedones and comedonal acne. And this is an extreme photograph, but this is what you would see with the first hormonal surge. And then a little later with puberty, as we have the gonadal organs kicking in, we actually see more of an inflammatory acne along with the comedonal acne and the oil and the oily scalp. And so this is really what we see when we see adolescent acne. And then something that I think many of us see commonly is the chronic acne that some women have. So obviously both men and women can continue having acne into adulthood, and certainly can continue having the traditional forms of acne, inflammatory and comedonal lesions all over. But I think one thing that a lot of us see frequently now is this sort of chronic low-grade cyclical acne that a lot of women get, where they're getting just a few cystic lesions or inflammatory lesions, mostly on the chin, sometimes on the lower jawline, the lower cheeks and the upper neck, but this sort of mild cyclical flare that can last throughout their entire adulthood. And if you look very closely at this picture, you can see some terminal hairs coming out of the chin. This patient's probably been plucking, but these women also can have a little bit of excess terminal hairs in the mustache area and the chin, and sometimes even have some thinning of the scalp hair. And these are women who don't have an underlying endocrinopathy or any hormonal problems, but just might have an increased end organ receptor, enhanced receptor function to their normal circulating androgens. And I think this is something that we see also. And if you look at this graph, specifically for women, this shows hormonal levels throughout a woman's life. And if you see at the beginning on the left at birth, you see that green, and that is the DHEA that we see at adrenarche when the adrenal gland starts kicking in. And if you look at the right, you're going to see that that perks up again later postmenopausally. But what you see in the middle is that women just have fluctuating hormones all the time. They have this cyclical hormonal fluctuation with their monthly cycle and their monthly period. They will have hormonal changes when they go on the pill and off the pill. They will have hormonal changes when they become pregnant and when they're postpartum and in between pregnancies. And then postmenopausally, when women lose their estrogen and their other hormones, their adrenal gland is still making androgens. And so we see increased oiliness, enlargement of pores, and acne postmenopausally. So in talking about generational dermatology, I think acne is like the poster child for condition that we see all throughout life. Now tonight, because we are also in the spirit of the barrier, I'm going to focus on skincare in acne. We all have our favorite treatments that we use, and we have a tremendous toolbox for treating acne. Topical antimicrobials, topical benzoyl peroxide, topical retinoids, oral antibiotics, oral hormonal therapies for our female patients, and even procedures that we do in the office. But what makes us unique in treating our patients with acne is that we have to take the whole picture into account. And I think skincare as an adjunct to our standard prescription treatments for acne is very important. And as we're learning more about the barrier and barrier compromise, and the fact that barrier is compromised in our treatments in our patients with acne, it's really important to discuss all aspects of skincare with our patients. Because if we just give them the prescription treatments, they may not be as compliant, especially if they develop any side effects early in treatment. So we want to take into account the fact that there's a barrier compromise in our patients with acne. We want to reduce inflammation in our patients with acne. We want to offer them camouflage to hide their lesions. We want to deal with the microbiome, which Dr. Alexis already mentioned, is certainly altered, and we lose that microbiome diversity in our patients with acne. We want to control oil, especially for our oily and porous patients with acne. And then we really want to take into account what vehicle to give when we give our patients prescriptions. And if there's any advancement that we've had in topical therapy, it's really the generation of vehicles in our treatments that are much better tolerated cosmetically than the ones that we had many years ago when I was a teenager. And if we talk about the vehicle in skincare, then we can really talk about efficacy and tolerability, cosmetic acceptability, and the effect on the barrier, not only of the acne itself, but the treatment. So when we talk about skincare, we have to take into account recommendations for cleansers, for moisturizers, including cosmeceutical ingredients, for sun protection, for cosmetic camouflage, and then for some of the sequelae of acne, including post-inflammatory pigmentary alteration and erythema. The vehicles and formulations utilized in prescription treatments, the popularity now of what we call clean skincare, which refers to microbiome-friendly skincare, And then talking about supplements and diet, which might help reduce systemic inflammation and inflammation in acne. And then just some of the at-home devices and peels and treatments patients can use as part of their at-home routine. So the function of cleansing is to emulsify and solubilize dirt, sebum, and irritants. But we know that surfactants can damage the stratum corneum, decrease lipids and natural moisturizing factor, and further compromise the barrier, leading to transepidermal water loss increases. So the choice of cleanser is going to be very important for our patients with acne, and especially with what they're going to be using in addition to this cleanser when we give them their prescriptions. So some of the moisturizing cleansers contain milder surfactants and emollient lipids that can actually be deposited into the skin. And generally, we want to tell our patients to avoid abrasive, harsh scrubs and alcohol-based cleansers. So when you give your patient their prescription retinoid, if they've been using a harsh chemical scrub in an effort to get rid of their acne, and you don't discuss with them what their cleanser is, and they go home and they use that abrasive cleanser and then put their retinoid on top, you're going to see a situation such as what Dr. Alexis showed in his picture. So we really want to recommend gentle cleansing, which will restore the barrier and which will also help enhance the microbiome, but most importantly, will increase the tolerability to the acne products that we're recommending to our patients. So even with patients with oily skin, when I start them on their prescription topicals, I always have them start with a mild cleanser. Now, for those patients who are very oily, or for those who live in warm, humid environments, and when it's very humid and they're oily, I might recommend cleansers that contain salicylic acid, which gets down into the sebaceous follicle and helps remove the oil. But I usually will add that in after I've gotten them acclimated to their prescriptions, which will strip their barrier a little bit more. One ingredient that I like to recommend is a cleanser that contains hypochlorous acid. This is an antimicrobial facial cleanser that has antibacteria, virus, fungal, and MRSA properties. And it also has anti-inflammatory properties. I find it very helpful, again, for those who have oily skin and those living in humid environments, but it is gentle and it adds a little bit of anti-inflammatory, antimicrobial properties. But again, I like gentle cleansing. As far as moisturizers, moisturizers will help with epidermal barrier repair and help improve tolerability without compromising efficacy. Dr. Alexis did refer to Dr. Tanghetti's study, which showed that if you use a moisturizer containing ceramides before you apply a topical retinoid, you will not compromise the efficacy of the retinoid, but you will certainly improve the tolerability. And I have to say, when I start patients on a topical retinoid, I always have them use the emollient moisturizer first and then the retinoid. So just as with Dr. Alexis, I don't have them use the moisturizer second. I have them use the moisturizer first and then the retinoid, because the most important thing here is you want the patient to be compliant. And if they get too irritated, or they don't look great, or they get a little dryness or irritation, they're just not going to use the treatment. So the ingredients that we can recommend in moisturizers include the emollient lipids, such as the ceramides, which were showed in the study to improve tolerability, but also products that contain humectants, which bind water in the skin and hydrate the skin, which include glycerin and hyaluronic acid. And then even anti-inflammatory ingredients, which we find in cosmeceuticals. And these include antioxidants, such as vitamin C and vitamin E, and vitamin B5, which is niacinamide. And niacinamide is a barrier repairing ingredient, which restores epidermal lipids, but it's also a potent anti-inflammatory and antioxidant ingredient. So it's anything that has niacinamide is also going to improve tolerability. And then there are the botanical anti-inflammatories, such as oatmeal and licorice and any of the other botanical anti-inflammatory ingredients. And then in the cosmeceuticals, we also have ingredients such as glycosaminoglycans, which hydrate the skin and also are anti-inflammatory. So these are all ingredients that you want to look for when you're recommending moisturizers to your patients to use to improve the tolerability to their products that they're using by prescription. Now, sun protection is obviously important for all of our patients. For our acne patients, it's important because of medication-induced photosensitivity, such as we see with oral antibiotics. Certainly for our rosacea patients who have an exacerbation when they get too much sun. And then our patients using the topical treatments that might cause irritation. So retinoids do not directly cause photosensitivity, but if a patient has a retinoid dermatitis or an irritated skin from the prescription products they're using, their skin is going to be more sensitive to the sun. So sun protection is key for these patients. We have newer formulations and delivery systems. So there's a formulation for every skin type: sticks, sprays, gels, which are non-greasy, powders, and compact and tinted formulas, which have physical sunblocks, which also have zinc oxide and iron oxides, which can help camouflage the acne. So if you have, let's say, a guy who has a hairy area where they have acne, such as on their chest or on their back, they might prefer a gel or a spray. And if you have someone who wants to camouflage their acne, they might prefer one of the compact tinted formulas. But we have so many choices now. Some of the newer ingredients to be aware of, besides for the physical sunblocks, are the phytolases or the DNA repair enzymes, which are liposome encapsulated. And these formulations also come in tinted. Now, cosmetics are definitely very helpful to help camouflage acne. When I was a teenager and wanting to wear makeup, I was told I wasn't allowed to wear makeup because I had acne. So obviously we've come full circle with that. And there are great formulations that will not exacerbate acne and might actually help reduce the appearance of the acne. Micronized powdered formulas of silica will help deflect light and therefore decrease the appearance of pores as well as fine lines. So you're not going to make pores smaller, but you can make them appear smaller because of the matte finish to these formulations. They also contain titanium dioxide and zinc oxide, which are physical blockers which will camouflage the acne. And they're also very mattifying. So the smooth matte finish makes the skin look and feel less oily. And the talc microspheres in these cosmetic products will actually absorb the oil. We usually recommend products that are labeled non-comedogenic and hypoallergenic. And also we can take advantage of green tint to camouflage redness for patients with acne and rosacea. When it comes to post-inflammatory hyperpigmentation, we have a lot of ingredients which help with that. Tretinoin, which the patient is using for not only their acne treatment, but acne maintenance to prevent recurrences of their acne, usually is our first line to treat PIH in patients who are prone to acne. Hydroquinone can also be used for the individual spots. Azelaic acid is very helpful for treating hyperpigmentation in patients with acne. And then, of course, glycolic acid, salicylic acid, and kojic acid. When I have a patient I'm treating for acne and their acne is under control and they have some post-inflammatory hyperpigmentation, my favorite prescription products for maintenance are actually azelaic acid in the morning and a retinoid at night. And as I explain it to patients, both of these topicals will both help prevent recurrences of the acne and will also help treat the post-inflammatory hyperpigmentation. So I find those two prescription items to be very helpful for patients with PIH. This also can be used with moisturizers that contain cosmeceutical ingredients. Soy and niacinamide both interfere with the transfer of melanosomes from melanocytes to keratinocytes and therefore help fade hyperpigmentation. Vitamin C helps fade pigmentation. Licorice extract, and then arbutin. And then, of course, we have our newer ingredients, tranexamic acid and cysteamine, that we're using for melasma, which also can be helpful for post-inflammatory hyperpigmentation. But again, when it comes to patients with acne, I like to stick to the cosmeceutical moisturizers paired with the tretinoin and azelaic acid. And then for erythema, specifically for our patients with rosacea, we can use our vasoconstrictors such as brimonidine and oxymetazoline cream, which are adrenergic agonists, which vasoconstrict vessels and therefore decrease redness. Of course, the cosmeceutical ingredients that I mentioned earlier, which are anti-inflammatory, the antioxidants and the anti-inflammatory agents. Intradermal botulinum toxin A is being studied and used by more and more physicians, which addresses the neurogenic vascular dysfunction in patients with rosacea. And it has been shown to reduce erythema of cheeks in patients with rosacea. And we know it reduces the oiliness when, for instance, we inject our patients on the forehead and see that the forehead looks less oily and porous. So I think we're going to be hearing and seeing more about this agent for treatment of both rosacea and acne. And when it comes to our prescription products, again, as I mentioned earlier, most of our innovations have been more so with vehicle changes rather than with new ingredients. And through the years, we've had improved delivery and improved vehicles to give us improved acceptability cosmetically of the existing active agents, such as retinoids, antimicrobials, including both antibiotics and benzoyl peroxide. And then, of course, we have our new molecule, which is an anti-androgen, which should help reduce the appearance of oil and pores and sebum. So with respect to the new topical retinoids, we have the new tretinoin 0.05% lotion, which is Altreno. And then we also have the new tazarotene lotion, which is Eraslo. And both of these products are made by the same company and have a similar delivery system. They both contain a polymeric micronized emulsion, which allows for localized delivery into the follicle with what's called a honeycomb mesh-like network, where the ingredients gradually penetrate nice and evenly into the follicle, but the vehicle also contains those hydrating agents, glycerin, hyaluronic acid, and soluble collagen, which allows them to spread and absorb easily. And so with this nice vehicle and these hydrating ingredients, along with this emulsion, we have these ingredients, tretinoin and tazarotene, which traditionally have been considered to be potentially irritating, which are going to be much better tolerated. Then we have trifarotene cream or Acleve, which is a new molecule or a fourth generation retinoid, which is a gamma receptor specific retinoid. And this actual retinoid has been approved for the face and for the trunk. And this also has like a nice hydrating gel formulation, even though it's called a cream. And I'm using it in the patients in whom I used to prescribe adapalene or differin, who might need to bump up to a prescription strength. But I should say that it's wonderful that we also do have adapalene or differin available now over the counter. And I still do use that very frequently in my patients with acne, again, along with the emollient moisturizers, but this is a very well tolerated retinoid. As far as what's new in antimicrobials, we have a topical minocycline foam, the 4% Amzeeq, which is for patients with acne, and the 1.5% Zilxi, which is for our patients with rosacea. And again, this has a beautiful delivery system. It has what's called a molecule stabilizing technology with a soluble hydrophobic triglyceride-based vehicle. It's not oily or greasy. There's no surfactants. It doesn't leave a large residue, but it has this emollient triglyceride-based vehicle. And it's a targeted foam delivery. So you can apply it to larger areas. You can apply it to areas that have hair. And what you see with this product is you get increased levels in the skin, in the sebaceous gland, because the triglyceride-based vehicle is hydrophobic. So it gets down into the sebaceous follicle, but there's very minimal systemic absorption. So we mainly have a localized accumulation of the antibiotic so that we don't have to deal with the concern of resistance, which we do when we're using some of the oral antibiotics. Down the line, we're also going to have an encapsulated benzoyl peroxide tretinoin combination. As of now, we have a combination benzoyl peroxide adapalene, but we're going to have a benzoyl peroxide tretinoin combination where a silicone shell actually wraps the benzoyl peroxide crystals so that they can slowly be absorbed with slower penetration and therefore increased tolerability with these very potent 2 actives in a combination that's actually stable. And then, as I mentioned earlier, I love using azelaic acid, and we have now the azelaic acid available in a foam, and it works beautifully for my patients with a little bit of oily skin who have acne or rosacea and concomitant pigmentation. And then there are some private label lines where they've combined this with niacinamide and glycerin to give a nice cosmetic effect. In terms of newer agents or molecules, the one new agent or molecule that we're all excited about that'll be coming out this year that's been approved is the clascoterone 1% cream. And this is a selective androgen receptor inhibitor or antagonist. It's a new mechanism of action, and it essentially modulates both sebum and lipids. And it basically blocks the androgen receptor at the sebaceous follicle. So it acts in the same way that spironolactone acts when we give that to our female patients. But this is a topical that can be used by both women and men. And in the clinical trials of over 1,400 patients in the 12-week study and the 52-week extension study, all of the primary and secondary endpoints were met. What's nice about this, again, is it can be used by women and men. It's very well tolerated, and based on the study, it was safe. It's metabolized to an inactive metabolite called cortexolone, and in the studies, there was no systemic exposure or effect on the adrenal hypothalamic pituitary or HPA axis. As far as the microbiome, Dr. Alexis already mentioned that this is a very important part of the epidermal barrier. It includes bacteria, fungi, and yeast, and that most of our barrier is diverse. We have commensal organisms, and our bacteria secrete antimicrobial peptides to help regulate our immune system and promote immune tolerance, and to also help maintain that acid mantle, that low skin pH. And if you destroy that barrier or lose that microbiome balance, the pH does go up higher, leading to more barrier compromise. And there is dysbiosis or microbiome alteration in our patients with acne. So what's become very popular is having microbiome-friendly skincare that does not disturb the microbiome and that it modulates to improve barrier repair and decrease inflammation. There are going to be a few exciting lines coming out that target the microbiome. One line is made by Crown, and I think that this is something we're going to recommend more to our patients. Prebiotics can support growth of good bacteria and help restore microbiome balance. And probiotics can be used both topically and orally. And these contain live bacteria, cultures, and lysates of commensal bacteria to help improve barrier and inflammation. In acne, some of the ones that have been looked at include topical Enterococcus faecalis, Lactobacillus plantarum extract, and Bifidobacterium. And in rosacea, supplements that modulate the GI microbiome, which is probably related to the changes we see in the skin microbiome that may help decrease inflammation and erythema. Keep in mind that when we give probiotics to our patients, it might not only be to help their acne in this way, but for instance, if you're giving a patient an oral antibiotic, you might give them a probiotic along with the antibiotic to have less of effect on the GI flora. As far as diet, we know that the Western diet is pro-inflammatory. We have a lot of carbs and sweets and unhealthy foods that affect the GI flora and that probably affect the flora in our skin and contribute to inflammation. And nutritional changes probably will decrease systemic inflammation. And we know that this is something that we talk about now with our patients with eczema, with psoriasis, with acne, and with rosacea. In terms of the role of diet in acne, probably refined sugars, starches, and dairy, and for some patients, gluten will play a role in exacerbating their acne. We know that skim milk and acne have been associated, and this may be due to the whey proteins in casein. And when I used to see males who got severe flare of acne come into me, one of the first things I would ask them years ago was, are you taking any shakes or supplements to build up muscle for sports? Because a lot of them were taking supplements that contained anabolic steroids. But now I'm also asking people if they're having a lot of protein shakes, because we know that smoothies and protein shakes have become very popular. And if patients are having a lot of whey protein in their shakes, that can possibly exacerbate their acne and may be responsible for their flares. So you might, for instance, want them to use a different protein source, such as a vegetable protein source. With respect to rosacea, we know that diet plays a role: tomatoes, spices, foods, and alcohol. And we know that there is a benefit of the Mediterranean diet for patients with all of the inflammatory conditions we treat. And this is not a standalone, and obviously it's an adjunct to the treatments we use. But when I do discuss diet with patients, I do recommend that they have the healthy oils, the omega-3 fatty acids, vegetables, fruit, whole grains, and those healthy fats such as in salmon and avocados and olive oil, and that they, stick away from the starches, the white rices and the sweets, and that they stick to the Mediterranean diet and even avoid dairy and sometimes gluten. And it's interesting that this is mostly cow-based dairy, and that they probably are going to be fine if they have sheep-based cheeses, if they really, really love their cheese and want to try modifying their diet. So basically, we want to recommend a low glycemic diet, which will decrease androgen bioavailability and decrease inflammation. As far as supplements, there has been some evidence that zinc supplements, along with other treatments, can be helpful. We know they're anti-inflammatory. We know a lot of people were taking zinc supplements when COVID started. Nicotinamide is used more, niacinamide, for patients with skin cancers, but anti-inflammatory potential. Again, I mentioned probiotics, which will decrease inflammation and restore the microbiome and might be a helpful adjunct for patients on oral antibiotics. And then ashwagandha is an anti-androgen, but it's used more in hair growth products. But who knows, maybe it has an effect on acne too. As far as the at-home devices which our patients can use, which are part of the whole discussion on what you can do at home and skincare, we have at-home devices for sonic cleansing to remove debris, dirt, and oils. And these are done mechanically with a gentle cleanser. Blue light devices, which might help with acne if the patient can't get into the office for it. Peels, which I use a lot in my office, which will help exfoliate. I use salicylic acid more than anything else. It helps exfoliate. It's lipophilic, so it gets into the sebaceous gland to remove the oils and the sebum, and it's related to aspirin, so it's also anti-inflammatory. It's helpful for the pores, for the acne, and the hyperpigmentation. And I also have products that I can recommend for patients to use at home. And then finally, masks can be helpful for unclogging the pores, and the masks that contain mud or those kind of ingredients. Clay can absorb oil, and also charcoal can absorb oil. And those might just help make patients feel better and look better. And that's it. So I think we're doing Q&As now.
Thank you. You covered so much territory. I know we have questions, but I hope everybody can just hang on and we'll get questions answered at the end. So rarely does there come a situation when things fit so perfectly together. And at GDerm, we have a winning product showcase, and we're going to go into that now. And this product is perfectly situated and has been set up by Doctors Berson and Andrew. I can't thank you guys enough. The product we're going to talk about, if you haven't heard about it, is called TheraWorks Protect. So this came into, I'll take the next slide. So this product came to my attention and during COVID, I'll take the next slide. So this product came to my attention during COVID. And let's just kind of go back to this whole COVID situation and masks and hygiene and we're the experts. Okay, so here we are, we're the experts. So these are my questions to our expert panel, everybody on the Zoom. What product do you currently recommend to prevent facial acne due to mask wearing? Does anything come to mind? Okay. Next question, feel free to chat with these too. What product or products do you currently carry or sell in your office that fall into the hygiene category? Okay. So, third question, how do you speak to your patients regarding prevention of infection? And then last, which was so intriguing to me during this COVID stretch, was determining what hygiene products were safe around the face and which ones weren't. So I found myself kind of asking myself those questions and wanted to bring this talk to GDermFresh because these are the kind of questions that have come up over the last 16 months. And even though, you know, we're coming out of masks, there's still this facial hygiene, acne, maskne thing that's out there. I'll take the next slide. So we're gonna talk about it and get a little deeper. So the question is, what is your go-to hygiene protocol? Are you like the lady with the thumbs up? I got this. Or are you just like pulling rabbits out of a hat, you know? Like I'm supposed to be the dermatologist. I think I know this, but really, do I? Do I? So this talk is all about simplifying things and giving us another wonderful tool in the toolbox. I'll take the next slide. And that's what this is about. So I want to thank TheraWorks Aberdeen for sponsoring this segment. This is a sponsored talk, and I'm so glad that you guys want to do this because it's a product that really we should all know about it. Next slide. So on the Zoom, I see you, Ralph.
I'm here.
Please welcome. I know you've been on before, and you're a fan of GDermFresh, and I appreciate that. But I'd like for you to talk to us all about why TheraWorks Protect. And Ralph Lombardo is the Senior Vice President of Sales and Marketing, and take it away.
Well, thank you, Dr. Roberts. First, I just want to say to Dr. Berson and Dr. Alexis, wow, what tremendous presentations. I learned so much this evening, and thank you so much. Avadim is the name of our company, and it actually means to serve. And what we're talking about is a product that was birthed in the ICU. And maybe the next slide can help us talk about this. This product was made by a Johnson & Johnson engineer who had a dermatology background. And last year alone, about 7 million patients across the country received a TheraWorks brand. And you'll see some of the hospitals, like just out there on the West Coast, you know, Stanford uses our product on every patient with a urinary catheter or a central venous catheter in their clinical bundles to prevent bloodstream infections and catheter-associated urinary tract infections. Kaiser, University of Southern California just published that when they used our product in place of chlorhexidine gluconate as the total body bathing product, they have been bloodstream infection free since February of 2018 in all of their ICU patients. Santa Clara Valley, you know, the Sharp system. So there are so many hospitals that are now using TheraWorks Protect for its hygiene. And Dr. Berson mentioned this about 4 times in her speak, a gentle cleanser that has potent antimicrobial, antifungal, antiviral benefits. So you can see the company, we have products in more than 50,000 pharmacies now. across the country. And that slide has gone very, very blurry for some reason. But we serve our military, and we're in nursing homes all over the country too. I love the lecture on aging and how our microbiome and how our stratum corneum changes over time. And, we need a pH, booster shot, so to speak, topically. And that's what this product is all about.
I know that the three talks just mesh so well.
Perfect.
And
Yeah.
it's really, tells the story. And again, we just, I think this is an area that we're just kind of getting started in. And, barrier health, not just for patient care. And you just spoke about that. What's a gentle product that we know is non-toxic? For me, it was really important that it's not toxic and we can use it on the face around the, eye area. And we need hand cleansing, we need facial cleansing. I know I have, kiosks now of this in my office for my staff and my patients, and we all feel a lot cleaner. We're really paying attention to our hygiene. And I know that, did I see Dr. Axe?
Yes,
He's here.
Are you on?
I am on.
Yeah, Dr. Axe, I know you've used this product.
Yes.
Yeah, so come on in. I would just love your thoughts about it. And Dr. Axe is an orthopedic surgeon. And thanks for coming on GDermFresh.
Yeah, well, when we started using it was when we had to wear masks for everything. And my staff started saying, I'm breaking out. I never broke out before. And our thoughts were, so back a year and a half ago, we started using it underneath our masks. And we found that not only was it great for our hands and that it wasn't an alcohol product and didn't dry out, that you could use it on your face, unlike many other things that we had available. We had chlorhexidine available to us because we use it in the operating room, right? We wash our hands, we do those things, but we couldn't really use it on our faces. And we found that once we started treating our faces underneath our masks, the whole problem went down. So I did this for about 18 months. And doggone it, when we stopped using masks and I stopped, we only used masks for certain times going into restaurants and so forth, didn't I break out, which I just laughed at myself because I stopped using my own treatment for this. We also had a great success with our wrestlers who have a lot of problem with acne. That's that adolescent time. And we have seen just a huge success with cutting down on the severity of the product. And it's inexpensive, so everybody can afford it. Not everybody can get to a dermatologist, but with my athletes, I'm just trying to keep them on the field, and many times that's not easy.
That's great. Well, don't go anywhere. I might need you to weigh in on a few things. I'll take my next slide. Thank you so much for that. So let's talk about the mechanism of action. What is it? What does it do? We know that it's a leave-on, and I'll take the next slide. I know, and this are the ingredients. So I don't know, Dr. Berson, are you still around? Because I know you're the ingredient queen. And it has a lot of ingredients that speak to its efficacy. And I know aloe is an antibacterial.
And aloe is an anti-inflammatory.
Mm-hmm.
And allantoin is an anti-inflammatory.
Go ahead, I'm sorry, repeat.
Allantoin is an anti-inflammatory, and colloidal silver is an antimicrobial.
Mm-hmm.
And I'm sure the citrus extract is anti-inflammatory, I guess.
Right. The silicone is important because of friction. We're going to get into the mechanism of action, but the dimethicone is really important. And we kind of, know that a lot when we're treating even, perioral dermatitis, right? We know that friction is a component of that. And I always have my patients use, products with dimethicone in them. So let's take a look at more of our mechanism of action of this. Oh, everyone can read this slide, right? So don't worry, there's no test at the end, but there have been studies done, and this just is a poster of a study which, Dr. Alexis talked about this pH. So this is an effect of an innovative pH lowering wound therapeutic and reducing MMP levels, right? So this product does a few things. We already know that a lot of our skin pathology is this creeping up from the alkaline, from the acid 5.560 pH creeping up towards 7. And we also know that this happens with age and an increasing barrier. We also know that metalloproteinase levels increase with sun damage, with aging, with oxidative stress, and all of those things that we know are associated with aging and just distressed skin. We also know that we have subclinical biofilms that occur that can contribute to a lot of pathology. We know biofilms from just our fillers gone bad, right? We all remember had to up our hygiene when we learned that biofilm reactions were happening as the fillers G prime increased, and as the fillers became more resilient, so did we see our increase in biofilm formation. So we know that biofilms are happening, and what's the perfect environment for that? A perfect environment would be in an area with increased temperature, covered by a mask, increased friction, with an increased pH. So the three, a high pH, increased MMPs, and bacterial biofilms is really a perfect storm for colonization, especially of chronic non-healing wounds. And I think we can all extrapolate that too, to not only non-healing wounds that we're going to look at in these photographs like feet, but also other inflammatory disorders of the skin, such as acne. Okay, so basically what they did, this is kind of like a pilot study, 2 studies, 10 patients in one, 20 in another. And the important thing is we're looking, it was a 4-week study, and we're looking at the wound bed, we're looking at the biofilm, and we're looking at MMPs. So I'm going to, on the next slide, we're going to dip in a little bit closer. And here you see a foot. This is one of the feet from the study. Again, this study was 4 weeks. So what we know about this product, TheraWorks, which we'll call TWX, we know that it down modulates pH in wounds and tissue, okay? And that was demonstrated. These were all in non-healing lower extremity wounds like diabetic ulcers, stasis ulcers. And the pH was moved significantly, 7.1 to 6.0. What we do know for sure is that this is a very potent proteolytic inhibitor of MMP9. We know that MMP9, one of those metalloproteinases, is overexpressed in non-healing wounds, especially radiation dermatitis, and also stomal contact dermatitis, and in the whole family of basically inflammatory dermatitis with these raging, cytokines. So the product TheraWorks protect reduced the expressions of these MMPs, and this allowed the wounds to be able to heal. And so what we see is the foot, plantar surface of the foot, and we see this very remarkable healing in 4 weeks. We also know, because of the ingredients, that there's a lot of bactericidal ingredients, and that really helped reduce the surface tension of the bacterial wall, right? Thus, lysis, easier, and also inhibiting the biofilm adherence. Because remember, the biofilm has to adhere. And that's, again, a physiologic phenomenon based a lot on inherent anatomy and temperature and pH and friction. Next slide. So there's a lot of mechanisms of action. And when we look at there's 3 boxes again, I know this is a very busy slide, but what I'd like everybody to focus on is the top box is the mean wound area baseline to visit for. So basically the lesion shrunk, and that's what we're seeing. So the lesion shrunk with daily application of this product. And then we look at the MMP9. I think that is most remarkable, a 72% reduction from 0.76 to 0.22, very significant p-value, and this really has meaning, reducing inflammation. And then we look at the percentage reduction of biofilm in all the patients, and we see that in a total of 20 patients, over half had a reduced biofilm. So you figure, and this is when I saw this data, I said, well, if it's doing this in these dire situations, you know, what can it do in skin and disorders that really are not as severe as this? Next slide. Again, here's some of the data. We see the 2 feet, just decreased biofilm, decreased MMPs. 67% of the patient healed greater than 30%, 72% reduction in MMP9. And as I said earlier, 18 patients started with a proven biofilm, and 10 were eliminated after 4 weeks. So I know we are all experts in our field, and I think the hygiene is an area that we really need to be an expert in too. And this is a great product to have in your offices. Next slide. Here we're looking at oxygenation. So this is a foot, and this is a foot ulcer. And at the beginning, the baseline top figure, basically oxygen is red. So we can all look at color and see that in a 4-week period, the area of oxygenation was increased, which is pretty remarkable for 4 weeks. This is an infrared image. Next slide. So we know that science, and how do we take it into what comes into our everyday offices? So I get to talk a little bit about maskne, and you see it on Instagram, you see it online, but it actually exists. And our Academy of Dermatology has dedicated space on their website to it. So a lot of this data comes from that. So maskne is basically mass acne. And again, this is in our wheelhouse. This is skin. And I wanted to bring it to GDerm because hey, June is Acne Awareness Month. What causes maskne? Temperature, high temperature, increased moisture, increased pH, bacterial breeding, and then the big culprit, friction, right? That constant rubbing of the mask against the skin. And we've no doubt, and I know, Dr. Berson and Alexis, and everyone has seen increase in facial acne from the very onset of COVID. Next slide. So what's interesting are these zones. So again, this is from our academy, outline these zones, the T-zone, which we all know, the T-zone, traditional acne area. But now we've got the dotted line, this U-zone, and this kind of a new area that has come up with COVID is this O-zone. And this is basically the areas of maskne. And these are, what the patients are coming in with. So next slide. What can we do about it? Again, on the AAD website, well, we have to manage the pH. We've got to, lower the skin pH and get it into that area where the skin works its best, which is an acidic. And how do we do that? Dr. Berson said it, antibacterial gentle cleanser. And what I love about the TheraWorks product is not only antibacterial, it's antifungal, and it's also antiviral. So the data is in on all of this. All of this information, guys, will be on the website, and you can reach out to Ralph as well. But the studies are done on this product, and that's why that very busy slide where it showed where everywhere it's been. Ralph, I said, how could this product be everywhere but not in my office? So it's in my office now. So it was everywhere, but as a derm, I didn't really know about it, and I just really wanted to bring it here. So I think it's important. It has a great barrier to reduce friction, and it also decreases acne. Great for adolescent acne. Great for working on your barrier, and I think that is the key. It's working on your barrier. It's preventative. It's got all the things that we want our patients to have. Reduces the pH. It's got those very gentle surfactants for cleansing. It's got the dimethicone. It's got the allantoin, which helps prevent that very fine scaling. And it's got aloe, which we know is hydrating, antibacterial, and anti-inflammatory. So again, TheraWorks Protect is a winner, and it gets our winning showcase product for our June episode. Michael, Dr.
Yes.
Atka, do you have any other things to add? Because I know, again, we'd love your
one of the things that we use it is every first aid kit on the sidelines, because we can use it for any open wound and any problems that we're having with that particular individual. It's phenomenally good on burns. And what the children like most about it is that it doesn't burn. So my grandchildren will come and get sprayed or foamed right away. And with the quality of the product, it's like a natural Band-Aid. We don't even have to cover it many times. And they'll come on a regular basis because there is no alcohol in it. Hugely saving grace. But we've had episodes in our office where young children have been burned because of hot fluids. We've used this instead of that messy silver nitrate and had unbelievable success with the skin healing perfectly fine afterwards. So we have found that this environment that's created has been very helpful for the healing process. Surgery wise, we use it on incisions if we're having any issues with that. And we sometimes use it preoperatively to lower the colonization prior to using the more harsh antiseptics that we use in surgery.
Thank you. That's a great point, because, the CDC guidelines basically call for, something to be at least for a hand sanitizer or a sanitizing agent to be at least 60% ethanol. And that does burn. So
it also dries, and that's probably a bigger problem. And I know that your staff is more likely to use this product with the dispensers that are available than they were the other alcohol-based products.
Yeah, I mean, we have a question, and I asked this question too. I didn't make the product, but the question is from our audience: why lavender? Very antigenic. Why is lavender added when many people are allergic?
Yeah, great question. We also have fragrance-free as well. Keep in mind that this is used in millions of patients in the perineum, and the lavender works pretty well in the perineum. Not for skin conditions, but for odor. And we have, and so many hospitals like the lavender fragrance.
Right. I mean, you do make it in 2 formulations. Excellent point.
We do, yeah.
And that's great. So, but lavender does have some good uses in certain situations. Next slide. I think that's it. Okay. Can we go back to June? I'm going to talk some more. We're going to talk a little more about acne. Thank you, Ralph. Thank you, Dr. Axe.
Thank you so much.
Yeah,
pleasure.
yeah. So I'm very excited about it, that product. Again, this is Acne Awareness Month. We talked about medical treatments, we've talked about products, but some of our patients really want to know what technology treatments there are. Topicals are often ineffective. Drugs can take many weeks to start. We all know how people are scared off by, Accutane, isotretinoin, and all of its different forms, and can be expensive, right? And a lot of people have had really tough times this year. And oftentimes your provider problems with the iPledge program, pregnancy risk. This is where we are with acne. We know via studies published, and the publications are listed on this slide, 65% of acne patients are non-compliant with prescriptions. So the bottom line is that many acne patients are not satisfied. On average, this statistic comes from Derm Times. They're visiting 5 dermatologists before considering going to med spas, seeking technology rather than prescriptions. So again, in this study, greater than 50% of consumers want technology to treat their medical conditions. I would love to know how many people on this call use technology, use devices, use laser as a first line treatment for acne. So if anybody wants to comment, please put in the chat, because I would love to talk more about that. Everybody's got their special sauce or special recipe, but who starts it first? I'll take the next slide. I'm going to go pretty quickly. And I'd like to thank Airlays, who is a sponsor for this GDerm. Thank you, Airlays, for always sponsoring and supporting GDerm. We appreciate you very much. The device that I'm going to speak about is the Airlays Neo Elite. It's a 650 microsecond technology. This is a 1064 neodymium YAG laser. And what the bottom line with this laser is, why does it work on so many entities and in so many skin types? Well, it's a fast pulse. It goes in so fast, it avoids collateral thermal damage. Therefore, you don't need to have any cooling, and you don't have to have any numbing. It delivers a very powerful energy in a very quick pulse. Okay. So, we'll go back. I know. Let's go to that. Yeah. So there's a lot on this slide, so I'm just going to kind of go through it. So we've got on your x-axis this pulse time, right? And we call it thermal relaxation time. So up to 800 is kind of the time that you can sneak in a pulse without avoiding pain. And the longer it takes, and the longer you go out on the x-axis, the more painful your treatment discomfort is. And the traditional laser technologies is out to here, and that's why it hurts, right? And so really the key is being able to get under the thermal relaxation time. And you want to deliver a pulse that's powerful enough to be effective, because if it doesn't go deep enough, then it's going to limit your targets. The Airlays Neo Elite has 3 targets. Let's look over here. And these are important because it tells you why it's so effective. It targets hemoglobin, it targets melanin, and it targets water. So you've got a device that really is colorblind. You can use it on all skin types. It's powerful. It gets in there, hits the target, gets out. Very little thermal diffusion, which causes PIH and pain. And that combination of a high power and a short pulse makes this treatment so safe and effective, and really my go-to laser in my skin of color patients. It's very predictable, very safe. Next slide. Now we're going to look at the chromophores. And why is this so important with acne? We look at active acne, inflammation, redness, right? Even, can be like rosacea, like, and we see what's happening. We all know the pathogenesis of acne, so I'm not going to get into that. But let's look at what happens when the neo-elite meets the chromophore, right? So for hemoglobin, it not only coagulates the capillaries, but what happens when you coagulate the capillaries? You start to kill the sebaceous gland. I'm going to show you some amazing photos from dermatologists around the nation that have been published with this device. So kill the sebaceous gland, cut the vasculature. Guess what? You're making headway, and you're going to see it. We know, again, obviously, with the hemoglobin, you're going to coagulate capillaries to reduce inflammation. And what happens when you have water as your chromophore for your laser? Well, what happens is you superheat and destroy P. acnes bacteria. And the bonus is you also, with the water chromophore, stimulate collagen to reduce acne scarring. So you're able to, and then there's a number 5, which I guess I walked away, but number 5 is that chromophore of melanin, right? So picture it all. You're able to decrease sebaceous output by hitting the capillaries. You're able to get rid of erythema, destroy bacteria, and stimulate collagen for people who have scarring. You can treat that as well as treat the PIH that we all know happens from inflammatory acne. And that's why this is so effective. Next slide. Okay, so, this is a before and after. This is a patient with, very severe jawline cystic acne, and she cleared in 4 treatments. I put up this article of mine because I was laughing, because if you look at the date of the article, it's March 2020, right? I never saw this article, okay? Because the last thing we were doing in March 2020 was looking at journals. But when I was doing my putting this talk together, I ran across this, so I put it up, and I thought it was pretty funny. Never having seen it, but it talks about it's in Practical Derm, and it talks about this laser and really how effective it is to treat skin of color. And if you look at the one of the photos in the picture, I love this for pseudofolliculitis Barbie. It is such an awesome laser for destroying the hair, because remember, it has melanin as a target. So it destroys the hair, gets rid of the PIH. It has collagen as the target, smooths the collagen. It just does great things. And that's the actual device. If you haven't seen it, I'm sure most of you have seen it, but if you haven't seen it, that's the device. Next slide. And this is a great study. This was just a recent study done by Arissa Ortiz right out here in San Diego, and Tanya Graywall, and they looked at acne with the 1064 nanometer with this laser, and they got nice results. Small study, patient improvement, 2 weeks after their treatment. All patients noticed an decrease in cystic lesions, and we're going to look at some photos. Well-tolerated procedure, all the things you really want to hear. The typical treatments are about 4 treatments average. I would say that's in my case too. I do the treatments about every 2 to 4 weeks, and feel free to hit me up or any of us up for the actually indications, spot size, et cetera, because we don't have enough time to really talk about that. But their conclusions, I think, are very important. They felt that this was a great treatment for acne for those with resistant disease to medical management, for those patients who are looking for alternative treatments, maybe burnt out, wanting something different. The advantages are minimal pain, no downtime, and being able to treat all skin types. So they felt that this was another great tool in their acne toolbox. Next slide. We're going to look at some, here's before and afters. We'll go through these kind of quick. We saw her, but this is a, I did her in, yeah, so you can see from February to August, she got really nice results, nice and smooth. And this is what our patients want. And I always talk about PFB in women, especially now with a lot of people hiding out under masks. Don't forget to ask your female patients about pseudofolliculitis, Barbie. More people have it than will actually admit it, and people are plucking and shaving and waxing, but a lot of times there's underlying pathology. Next slide. This case is amazing. When I saw this case, I think I saw it at Scale, Dr. Gold, it might have been at GDerm actually, Dr. Gold presented this. I said, you have got to be kidding. Can we go back? I said, you have got to be kidding me. This patient had 5 treatments of the Neo Elite, had failed Accutane. And here she is 13 months after. Next slide. He published a paper on this, and this is available. He did this during COVID, and it's available, and it talks about treatment. In this paper, it actually, he's doing it with, with Accutane and addressing the fact, can you laser with Accutane or not? But it's a good paper, but some of the results, let's look at some more slides because I want to move along. Some of the results, these before and afters of just the Aerolase alone are really phenomenal. I'll take the next slide. This is just acne treated with the Neo Elite. Again, 3 months after 5 treatments, really nice responses, and so safe on skin of color. This is kind of like what we're seeing, right? This is a typical patient of now. She's wearing a, let's go back. She's wearing a mask all day. She's got like classic, jawline acne. And we learned a lot today about different medical treatments and the way we want to treat her. But again, the Neo Elite is an option, a technological advancement for the treatment of acne, and you can do it first line. Next slide. So in summary, I just wanted to really talk about this and our patients who fail medical treatments and might want, need technology. So in general, it's just like a regular case. You come in, you assess them. The patients are pretty happy. There's really little downtime. The treatment time takes about 10 to 15 minutes. And number of treatments, 5. Yeah, I would say I've gotten people clear. I would say my average is probably about 4. And then the company posted this acne treatment package. So, let's say if you take the 1,500 on the high side, that's actually they have that on the low side. So that's like 300, which is, pretty affordable, 300 per session. Pricing just depends on where you are. But I think that this technology does allow you to be more flexible and have another tool in the toolbox and have something that you can, pull out of your toolbox and say, well, let's try this and have it, then make progress. So thank you all for your attention to that. And we're going to go on now. And I love our next speaker. He's awesome. Welcome back, Dr. Forrest. Dr.
Thank
Forrest,
you. It's great to be here.
Dr. Forrest is going to speak about telemedicine. And he knows because he's a pioneer in the direct primary care model. And he really is an originator. He has extensive experience in teaching and lecturing. He's the CEO and founder of Access Healthcare. and he's from North Carolina, and he's going to speak to us today. I think I had a question for you, Dr. Forrest. Might take the next slide. I love this because he is going to help us move along. And feel free to chime in, Dr. Forrest, but right, some of the questions, do you have a telemedicine program? Are you getting telemedicine referrals?
Absolutely.
How do you convert your telemedicine patients into mainstream patients? And
Yeah,
then,
I would say there's about a 75% ratio of conversion.
oh, wow. Wow. And would you agree, Dr. Forrest? Because I've heard that telemedicine is the fastest growing medicine revenue stream for a person's practice.
It can be, especially when they're initiating it if they haven't had it as part of their practice before.
Well, I'll let you take it from there. These were the questions I had.
Okay, give me just a
Thank you.
second to share my screen.
Sure. Thank you so much.
Okay, it's great to be on the second one of these symposium. And I know my presentation isn't on this, but I'm just going to have to pile on a little bit. I've been using the TheraWorks in my own practice for about 6 months.
Oh.
And, you know, I really feel like it's almost a necessity in our practice now. We use it on our face under the mask. We use it on our hands as sort of a pre-treatment. You know, the practice, we use it every day. And then on the weekends, I use it on my family. My 3 children don't go in anywhere that's public without basically lathering up with it to give themselves some extra barrier and protection. And I've done a lot of experimenting with it myself. It's interesting. The orthopedist mentioned this, but you know, anytime I've had a little cut or scrape, instead of immediately putting polysporin on it, which is sort of what I've done in the past, I've just, you know, put a little bit of the TheraWorks on there. I've really been astounded by how well it does, and it keeps the inflammation down. It doesn't get infected. So not to pile on about that topic, but it is something we use in our practice, and our patients use it. And so it's worked really well for us. And we've been using it, I think, for about 6 months now. And it does definitely help with masks. So there's a testimonial from somebody who's been using that for a little while. So what I want to talk about today is direct primary care as sort of a side topic, because that's something that, you know, I'm very passionate about. It's a model that I've initiated 20 years ago, but how that can apply to dermatology, especially, you know, we just came through this COVID epidemic, and a lot of fee-for-service visits may have been limited. You know, patients through the door went way down for a while. I know that was devastating to a lot of practices that had anything considered elective. And so we're going to talk a little bit about, you know, primary care, but what I want to quickly do is turn that towards, you know, the telehealth model, and how you can have teledermatology and how you can have direct dermatology care, and what that can do for revenue for dermatologists. And then also how, you know, there's sort of a infrastructure in place now, both with our network of practices around the country and with a fairly large network of dermatologists, where we can do consults virtually, where we can do referrals basically nationwide to dermatologists who are in GoMD. So we're going to talk a little bit about that. To those that may not have been on or don't know a lot about direct primary care, essentially it's like a gym membership for healthcare. So, you know, instead of somebody coming in and paying for an office visit or a cholesterol test or a diabetes test, they just pay a monthly fee, and then everything's included. So we include the office visits, we include the you know, lab work that they need, follow-up visits, and that kind of thing, which really helps a ton with compliance. Some of the things that are really good, direct primary care usually saves people who don't have insurance a lot of money. The quality is improved dramatically. We've shown national data with 65% reduction in ER visits, over 60% reductions in hospitalizations, chronic disease care in the top 10 percentile across the board for diabetes, lipids, and hypertension. It has complete price transparency. So, you never have a patient who gets to the checkout window and wonders what their bill is, because every month they pay a certain fee, and that sort of covers what they have done. But it dramatically lowers overhead. We don't spend a single dime on collecting money. That helps practice financially. The overhead's much lower. It also improves access for those people who have really high deductibles, or people who don't have insurance at all. So possibly something that could give some of those folks access to quality dermatologic care as well. The downside, it is a major transition. I mean, shifting your gears, your mind from coding and billing and worrying about, how you're going to document to get paid by an insurer, to all of a sudden that just disappearing, is a big transition. And the other part is, there is sort of this copay culture out there. People who have insurance, they're used to plopping down their insurance card and paying a copay. And so it is something to get used to for a community that, hey, I don't pay a copay. They're not filing my insurance. I just pay a monthly membership fee. The math of this is pretty simple, and this will apply pretty much to dermatology as well as primary care. I know I spoke at the American Academy of Clinical Endocrinology a couple of years ago at their meeting in Las Vegas, and because endocrinologists were wanting to get into this model, and it turns out these statistics work for pretty much every type of outpatient practice. So on the left, you have the fee-for-service model, and what you can see is typically across the United States, we're getting about 65% collections of what gets charged. The overhead is about 60%, which leaves about 26 cents on the dollar. In a direct care model, since you're not worried about insurance companies not paying the revenue, you're not worried about a code that gets mismatched, you're not worried about advanced beneficiary notices, collections is right at 99% for us for the last 19 years. And the overhead runs about 18% because we're not doing any billing, we're not doing any coding, we don't have any accounts receivable, which leaves 81 cents on the dollar. So if you think about that for a second, if you on the left were to charge $1 and on the right you were to charge 50 cents, you would actually have more money left over, charging half as much in this model. What about physician income expectations? Well, and this is basically, I've sort of mocked this up for dermatology. But if you go to an all membership model for dermatology and you had, 3 visits, for, 25 visits a day, 3 visits per person average per year. You take your number of members, you subtract 200, which is basically the fixed overhead for a membership model practice. You multiply that membership fee times 12, and that's your annual salary. So you see what it is there with 2,000 patients. And what's cool about that is that's net salary without ever charging anybody for an office visit or anything in the office. That's what's really cool about it. There are some practices that do hybrid fee for service where they may do a membership model and then they may do traditional billing for their better payers, or some just do Medicare only for their billing and everybody else they have on a membership. So that's an option. And then what I also want to talk about specifically is virtual dermatology via GoMD. So GoMD is more than a telehealth platform. It's sort of a community of health resources. It starts with telemedicine access to primary care, also has discounted healthcare services, discounted medications, access to mental health for a monthly fee. One of the things we offer in GoMD is the ability to see a mental health professional via telehealth 24/7, and that's only $10 a month for that fee. So we have people like first responders, municipalities that buy that for their firemen and their police, especially in this past year where they really wanted to have access to that for first responders. And that's really inexpensive to have that kind of access for mental health. So imagine having that same model for dermatology. Lawyers are willing to buy that, individuals are willing to buy that, where you say, look, there's a monthly fee. And if I've got a skin lesion that looks a little suspicious and I want somebody to look at it, or if I've got a rash or I've got something I want people to look at, or I want them to follow my acne virtually, well, you know what? The resolution on cameras has gotten really good. In fact, sometimes I can see things better on telemedicine than I can in person, because in person, I'm not, I don't have the assistance necessarily of magnification unless I go and get that out of a drawer. And people, do 10x magnification on their skin or on something they're trying to show me. I really can see it really well. So again, just mock analysis I've put up here. What if you had 2,000 virtual members, virtual patients? That's $240K. And visits are shorter when you do telehealth visits, because there's not the check-in and check-out procedure. There's not the walking them down the hall into an exam room and walking them out. So typically people can do 6 per hour and not even necessarily have to have the overhead of a brick and mortar office, which is really interesting, because think about how much office and facility and electric bills and everything else that goes along with an office is. So you can add this on to an existing practice if you already have a brick and mortar practice, but you can also essentially have this available as a freestanding thing. So like a dermatologist who just got out of residency, who didn't want to take on a huge amount of debt, they could do an entire practice this way and have no brick and mortar overhead. Or a dermatologist with an established practice who maybe fee-for-service visits have fallen off because of COVID. This is something they can easily add into their practice, fill that empty space in their schedule with, really, really do well. So the other thing is, although I'm a primary care physician, I actually do have a lot of laser equipment in the office. I've been very interested in dermatology and aesthetic for years. And so you can do memberships for aesthetic cosmetics as well. You can include a certain number of procedures. You can also include products at a discount. And what this can do is that membership is creating a constant revenue stream regardless of the in-person utilization. Can be layered on top of other revenue, and the consumable cost can be built into it like a gym membership. So I always like to give people the gym example. When you go to the gym, you pay your monthly fee every month, and you don't pay anything extra to walk on the treadmill. You don't pay anything else to lift weights. However, if you go over to the smoothie bar and get a smoothie, you do pay a little extra for that. Well, it's the same sort of thing. So the membership essentially entitles people to the 90th percentile of services you offer. And if you've got products that you want people to be able to buy, like, for example, if they wanted TheraWorks, or you have, special procedures or laser that you want to do, you can still, revenue on top of that membership. And then the patient sees the membership as a value, because you can give them a 10% discount, for example, on Airlays. Somebody could say, hey, it's $50 a month, but that $50 a month is going to get you 10% off your Airlays treatment. And they see that as a huge value. The good thing is, if they're not getting treats, you're getting that monthly revenue. So anybody who's ready to transition to a direct care model, it does work for dermatology. You can send email at the top to accesshealthcaredirect@gmail.com. We also have a lot of articles on DPC on the Twitter feed at Novadoc. And if you want to become a GoMD teledermatologist, you can go right there to gomd.care / become a GoMD provider, and you can sign up to do that. We'd love to have you on board. We're very, very excited about bringing in other specialists into this direct care network. And it really creates the ability for cross referrals. If I have a patient that needs a dermatology consult, I can literally virtually refer them to somebody. And I can also get a virtual consult. So you have 2 ways of sort of, getting business from being involved in that. You also can work for GoMD as a teledermatologist, where essentially people will buy a membership. And then if you are the doctor who looks at that rash, or you service that visit, GoMD can pay you a fee on top of that as well. So those are some of the things that we have available. The network is growing. We have hundreds of direct primary care practices across the country. We also have added cardiologists, endocrinologists, dermatologists, even some non-invasive cardiologists. The model works really well for any specialty that's primarily outpatient. So we also have a way, if you'd like to join the network, just to have access to our newsletter, or if you'd like to have access to group discounts on things like laboratory and things like that we have, you're welcome to do that. And anybody who emails me, I can send you a application to do that.
I thank you so much, Brian. That was awesome. Thank you so much. Great information.
All right, and any questions would be great. We've got a couple minutes here.
Yeah, that's good. And everything, guys, everything, including all of the GoMD information, will also be on the website. And if you're interested, reach out to Dr. Forrest, reach out to the website, and we will get back to you on that. I think it's a great opportunity. Any questions? We have a few minutes. Any questions about anything? No, anything? The talks were so good tonight. And I just want to thank our speakers, Dr. Berson, Dr. Alexis, Ralph Lombardo, Dr. Axe, Dr. Forrest. And may I have the slide? I have the date for our next GDermFresh. And the next episode is July 13th. And we're going to be talking about diversity in dermatology and gender neutrality with, again, a phenomenal group, Dr. Jonathan Breeden, Dr. Mona Gahar, and Dr. Ava Shamban. So that's going to be some really great talks. And don't forget our live meeting. GDerm is back February 18th to the 20th. Thank you, everyone. Have a fabulous June. Enjoy vacations, graduations, and all of that. Be safe.
Thank you.
Stay well.
Much.
Thanks, everyone.
Thank you.
Pat and IT. We have a great
Night.
IT team. Thank you.
Wendy, and thank you for all the great speakers.
Hey, Nancy. Hi.
Hey, how are you?
Oh, good.
And I want to thank the great speakers, and thank you. So.
Yeah, it really was. I just think we should have a glass of wine or champagne now.
Yeah.
Virtual hangout.
Or vodka.
Right?
Oh. All right.
Have a great night. Thank you.
Thank you, everyone.
Good night. Thank you.
Eva, hi.
Hi, Wendy.
Hi, Diane. I see you.
Hi.
And Felix, Bob, I see you too.